Hello, welcome to Mod Midwives, a Metro Midwifery podcast. I'm Gina Gerboth.
And I'm Nedra Hale, and we are home birth midwives serving the Denver metro area.
Well, welcome to the new week. Welcome to the new podcast.
This has been a really weird week so far. I don't know about you.
It has been a really busy week. I was in Austin last week for the Meek board meeting, and I feel like I have just been chasing my tail ever since trying to get caught up.
Yeah. I mean, when we looked at the calendar on Sunday, I was like, I already thought I'm already out of time for the whole week.
Yeah.
Like, it hasn't even started yet.
And we're recording this on a Wednesday, so it's we're like halfway done.
We're still not done. We're far from done.
Yeah.
I wanted to see if you had seen this article go by about this is the headline. Panic-stricken dad in just his boxers saves wife and baby's lives using shoelace. Have you seen that? It's all over Twitter right now.
I have not seen that, not being a dedicated Twitter user.
So when I saw it go by yesterday, I thought to myself, how did this man save his life, save his baby's and wife's life with a shoelace?
Don't tell me.
Is there surgery involved?
Don't tell me it's what. Don't tell me.
It is.
No.
It is that. He saved them by putting the shoelace around the cord. You know, I believe at the instructions of the
paramedics or EMS
on the phone. Yeah. Yeah.
Oh my gosh. Well, we should just debunk that myth right now that if your baby, well, we probably already did.
I think we've already talked about this, but I mean, just in case, oh my goodness, you guys, please don't put a shoelace on an umbilical cord.
A nasty, dirty shoelace?
You've got a fresh new baby that has come out of this sterile environment or at least a safe bacteria environment inside the mother's body, and then there is a gross shoelace introduced into the picture to cut off the circulation of a cord that does not need to be messed with at all. And this shoelace has been in public restrooms. Please don't do this.
Despite the fact that there's a giant body of evidence suggesting that delayed cord clamping is a good thing to do, the EMS is still recommending this.
This is like the focus of all of these emergency phone calls, it seems like anyway, is make sure you get that cord tied off. Nothing is going to happen if you don't tie the cord off. Like, it is...
Well, in fact, it's beneficial.
Good things are going to happen if you don't tie the cord off. Nothing bad
The baby will get stem cells and adequate iron stores and be less likely to have iron deficiency anemia.
Also, that risk of infection that has been introduced by the shoelace is removed.
I know you do not like germs, so that is a particularly bad.
It's like a horror. I don't even like touching shoes, with my hand.
No, that is not okay. Not okay. Plus, I have a lot of male people in my house who let's just say there's a lot of splashback.
Oh,
sorry.
Yeah,
Did I just ruin that for you?
That is something I hadn't thought of.
There's just splashy messiness when they pee standing up, I'm just going to say. Well, this is not actually the topic of our podcast.
What are we talking about today?
So, November is Prematurity Awareness Month.
Oh, okay. Right. And it is, we've got World Prematurity Day coming up.
Yeah.
On the 17th?
17th of November. So that'll be just a few days after this airs. Is airs the right word? I don't even know. I think it is.
Posts? I don't
Posts?
know.
Yeah.
I don't know what
maybe
is.
Because it's streaming. It's not radio. I bet that's right. Well, so preterm birth is something that happens. 1 in 10 babies are born prematurely.
Wow.
Yeah. 10, or maybe even a little bit more. 1 in 10. And premature birth is a birth that occurs before 37 weeks gestation. So, full term is considered 37 weeks on, and usually we actually call the 37th and 38th week, we call that early term. So even those babies aren't really quite up to speed yet.
I mean, clearly most of our babies come well after that, but I do remember a couple of babies that I've had that were born at 37 weeks and change and had to go into the hospital because they just had a little bit of wet lungs still.
Was that in Arizona or Colorado?
In Arizona.
Yeah, so Colorado is probably even, I meant to see if I could find Colorado statistics, but I do believe our preterm birth rate is a little higher than the national average. I would have to verify that. I'll verify that for the blog post.
Yeah, that would be great information.
Yeah. Yeah, because of altitude, I think.
So when I practiced in Arizona, and I don't know if the rules are still the same, because they did a big major thing overhaul on the
they changed
on
a
the
bunch
rules
of rules
after I left. But when I practiced there, we could deliver at 36 weeks at home, and again, not very many babies came that early, and we did have one or two that had to go into the hospital between 36 and 37 weeks, and then we had some that were fine. So it's, I mean, it just depends on the circumstances, I guess.
Yeah. So here in Colorado, we are not allowed to attend a birth before 37 weeks.
Right.
So that's our guideline here, but it is different
Which
in
I
every
think
location.
is completely reasonable in every way.
Right. Right. Because there can be things.
Yes.
Now, that being said, I have transported a couple of, or really didn't transport because we didn't, labor started and we went right to the hospital, but have sent a couple of clients to the hospital, 36 and 2, 36 and 4 days.
And it's such a bummer.
Because
they're so close,
Yeah.
But it's, the chances of having to transfer are, clearly higher. And
Right.
I mean, besides the fact that it's not appropriate according to regs and honestly, according to just standard of care.
Yeah.
So, it's just not something we can do. Sorry, guys.
Yeah. So let me say one more thing. Preterm labor doesn't always result in preterm birth. So sometimes you can have preterm labor that doesn't continue, that can be stopped. And it's sort of changing. They used to do some different drugs like terbutaline and stuff, and I just don't think they're doing that very often anymore. It looks like the calcium channel blockers, which I think is nifedipine. I'm probably going to get corrected about this later.
I need to do some more reading about
it looks like those
topic.
have some good evidence behind them to kind of stop. But the terbutaline, the stopping the contractions, isn't used very much anymore.
Oh, I mean, I think that's great news. And I really wasn't aware of that, actually, because it was an uncomfortable medication from the reports that I've received.
I think it made people feel really yucky, and like they had a racing heart rate.
Yes,
and stuff
exactly.
like that. Yeah, lots of side effects. Good. So there's a number of risk factors associated with the chances of having a preterm birth. Some of these risk factors are things that can be changed or modifiable, and some of them are things that can't. So what would be an example? Like, what would be a modifiable risk factor that you know about?
I mean, so lifestyle choices. So smoking, diet, and those kinds of things are things that you can modify. And the things that you can't modify would be like a socioeconomic factor. Right.
Race is a significant risk factor for preterm birth. Hang on, I pulled this up. Oh my goodness, there's so many tabs open on my computer. So according to the HRSA, which is a government agency, actually the overall preterm birth rate was it increased from 10.2% to 12.8%. But if you look at Black women, their rate of preterm birth is up to 16.5%. So it's a really significant jump by race.
Yes.
So obviously that's something that is just that's just something that is a result of, we think, chronic stress that results from racism. So it's just kind of the impact of having all of that extra stress on your body over time. Okay. So socioeconomic, you said, is a non-modifiable risk factor. Age is a non-modifiable risk factor.
So what are they saying about age?
Older and younger, actually.
Oh, interesting.
Yeah, adolescents and those over 35.
Those old ladies over 35.
Right.
I know. I mean, that's always my button topic. You know?
I know. I saw you cringe when I said it. Sorry. And fertility treatment is a risk factor.
So I was reading about that too, and I'm curious why. Do we know what the mechanism that is the association?
There seems to be something. So, of course, with fertility treatment, you're more likely to have multiples, which is an independent risk factor. Yeah. But also the fertility processes of in vitro fertilization are an independent risk factor. So it probably has something to do with implantation of the placenta.
Okay.
But it's probably a little bit over my technical knowledge level.
Yeah. Okay. That's just one of those things to dig into with, there seems to be an associated risk of a few different things with in vitro. Yeah. So it's kind of interesting. Yeah. We'll have to add that to the research list.
Yeah. It's really a big, important issue. So we've seen that it's going up. We've seen that, there's some things like race and socioeconomic status that are just really a matter of how you walk through the world. But the implications of preterm birth are really, really important. So babies born preterm are more likely to have problems with physical development, learning disabilities, communication disabilities, even things like cerebral palsy, neurological disorders. I believe things like, eye vision problems, hearing problems, a lot of things like that. Lung problems, asthma.
Right. I always think of the lungs and the learning disabilities and interesting.
Yeah. So really there's a lot of implications to being born preterm, and not the least of which is financial.
Yes.
So one resource says that one family, the cost per family for having a preterm birth averages $2 million.
Oh my goodness.
Over the lifespan of the child. So of course the NICU stay is extremely expensive. Yeah. I don't even know what the average per day stay of a NICU is now.
I have no idea. All I know is that, I just had a few minor things done, like comparatively, and got, the charges were outrageous, like $40,000 for these.
How long was he in there? Was it the NICU?
I'm talking about the things I had done recently, the testing.
Oh, your medical procedures. I was thinking about your youngest who was in he wasn't in the NICU though, was it?
And when he was at Children's for just backstory, everyone, my little guy had RSV when he was about 13 months old and was hospitalized for 5 days at Children's Hospital. And actually that one wasn't too crazy.
Really?
I mean, that sounds ridiculous when I tell you the number, you're going to die. But it was about $25,000, which is what I would think would be, expected, unfortunately, in the structure that our medical system is. But I had insurance and it was fine. We paid off, as everybody does. We set up a payment plan and paid off what our portion was. But I think even between then and now, things may have changed a little bit. And I am hearing people come out of there with, 100,000 plus hospital bills. And then you're talking some really big numbers right now. I mean, so I don't even know. And, people, not to go off on the, on the whole topic of the medical system and everything, but I think that there's no disclosure of costs. And so it's just like, you don't even know what to expect.
Right. You can be really surprised. You can be told that your insurance isn't going to cover something after it already happened and nobody said, by the way, this doctor isn't in your plan.
Right. Or you don't have the opportunity to decline a procedure, or the insurance company decides whether a procedure was appropriate that was necessary for living.
Right. And we could actually plug Dr. Stu's podcast, his Halloween episode. He talked about a couple that had late preterm. Am I saying that right? So they were 35 weeks or something like that. They were still preterm, but they were not, micro preemies. They were twins, and they talked about their NICU experience state, and it was really tough. It was tough to listen to. That's why it was their Halloween episode, because it was a scary story. About how clever. They felt like they had a really hard time advocating for themselves and their babies and getting their babies out of the NICU.
Oh, no.
And
I need to listen to those.
Yeah, it was really good. So, little plug for Dr. Stu. Maybe he'll listen. I sort of doubt it, but you never know.
He's all famous.
Exactly. We'll tag him on Instagram.
Those poor babies. And then, I mean, what a stressful situation.
Yeah. Terribly. And we talked a little while ago in our podcast about trauma associated with birth, and NICU stays are a often mentioned source of birth trauma.
Yeah,
So,
I mean, of course.
very, very difficult to happen. So anyway, so those are some things that can happen with preterm birth and some costs. And of course, some of that isn't just the hospital stay, it's the subsequent therapy and other treatments.
Yeah, and there's probably lost wages. I mean, there's a lot of costs.
Economic impact, overall economic. Yeah, that's a good point, too. I didn't think about that. So what are some signs of preterm labor that you kind of are keeping your ears open for?
So, as a midwife, we talk about this, of course, with our clients a few times during pregnancy, but and it's kind of, we touch on everything probably at every visit just a little bit. But, we're looking for any kind of regular rhythmic contraction activity would be concerning if it's not supposed to be happening. Cramps, feelings of pressure, which can be tricky with multips who feel like the baby's falling out all the way.
Time.
Yes, I remember that feeling well. Unusual discharge and bleeding and pressure that shouldn't be there, like I said. And backache is a thing that could be a concern. And I'm looking at the list right now. Yeah, the trickle of fluid from the vagina.
Also tricky.
It can be tricky. I mean, so at first you're like, obviously, but no, actually, it
Not so
can be
obvious.
super tricky.
Yes. You can leak urine. You can just have increased vaginal discharge.
Yeah,
That's
sometimes
normal.
it's really watery.
It can be really difficult to tell what's what sometimes. So you always want to call your provider if you have any of these symptoms and make sure they can usually rule it in or out pretty easily.
And I think it's really important for people to know also that if we are actually having a preterm labor that is going to result in the birth of a baby, these labors sometimes go really fast.
Right.
And so so we should not mess around with it.
Sorry.
If we're having that regular contraction activity, we need to know about it and we need to act on it quickly.
Yeah. So what are some things that people can do? What do you usually recommend to prevent preterm labor?
So first we're reviewing the history
Right.
of the client and seeing what risk factors are there. Has this client had babies close together, particularly this pregnancy? Has it been a short interval between the two pregnancies? Of course, any kind of history of preterm birth. There's major risk factors like incompetent cervix, that kind of thing. Multiples, of course, which we don't do, but that is a big risk factor.
But it does happen. In some states it is in the scope of care of midwives. So
yeah. So just because we don't doesn't mean other people don't. So what about you? What am I missing?
The three big things that I tend to think of are, so the three big causes of preterm birth are short pregnancy interval, like you said. So 6 months from the end of your pregnancy to the next pregnancy, less than 6 months. Stress is highly associated with preterm birth, and also infection. So one of our big jobs is to screen for infection So sometimes people will say, because we do a routine urine culture at the first visit, and people are like, well, I know I don't have a UTI. And actually, a lot of UTIs are asymptomatic, and they can trigger preterm labor. So
Yes, of course.
that's definitely something that we keep an eye on. Other, STIs, that kind of thing too.
And also dental infections. So it doesn't have to be in the genitourinary tract. It can be.
Right. That's actually really important. We try to remember to ask people, we have a handout on it, but, making sure that your dental care is all up to date and that you're not letting something go. Dental care during pregnancy is safe. And so it's better to go forward and get that treated
Address
than
problems.
to put it off until after pregnancy, when it will almost certainly be much worse. The infection will be much worse.
And it will probably be put off again after the pregnancy.
Then you're going to have a baby, by the way.
Yes.
So
it's not easier to get things done when the baby's out.
Definitely not after the baby's out. That is one of the most biggest myths, I guess we would say, about there's no more time after than there is before.
No.
There's a couple treatments for the prevention of medical treatments for the prevention of preterm birth. Cerclage, you mentioned an incompetent cervix. That's a procedure that they can do to essentially put a stitch into the cervix and keep it closed if the cervix. And by the way, is incompetent cervix not a terrible name?
I don't know. I was wondering if there was a new and improved way to refer to that.
I don't think there is, but it's terrible. It's so judgy.
It is
like oh, your cervix is
it's not competent.
You are not competent to be carrying this baby. Cerclage is, I think, I don't have a lot of research on this. Obviously, we do not do this,
right?
But it's more effective if it can be done preventatively than if it's done after a preterm labor episode has happened.
Right. Once the cervix has started to change, that would be harder.
Yeah. And then kind of the treatment du jour is progesterone therapy. I'm seeing a lot of people take progesterone throughout their pregnancy now.
So is this just people that have other risk factors for preterm, or are these people that are...
It's, I think it's really highly variable from provider to provider.
That's what it seems like.
Like highly variable. So some doctors would just say, if you have these certain risk factors, if you have a history of recurrent miscarriages, kind of those sorts of things, they would maybe start you on a progesterone therapy. But some doctors are doing it for a history of one miscarriage, which is really quite common.
Right. Totally.
So, it's really hard to say. I think I've seen a lot of variation there. I think.
I want to learn more about that.
So I did look up one because I wasn't... the last I had read... it was unclear if it was effective or not, and I wanted to just kind of do a quick search. And the American Family Practitioner, I always get their AAFP, American Academy of Family Practitioners, they grade progesterone therapy as a grade A. So it's got some good evidence behind it now.
Okay.
And one study showed that for somebody that was on a progesterone therapy course, the reduced risk of having a baby before 34 weeks is 69% reduction in preterm birth before 34 weeks, and a 45% reduction before 37 weeks.
Did they specify what the protocol was?
They probably did deep in the study.
Yeah.
I'll link it in the blog post.
That.
Yeah. Yeah, so...
because there's so many protocols, like what we were saying, so I'm curious.
Yeah. One other thing I wanted to mention. Half of all episodes of preterm labor that lead to preterm birth begin with intact membranes. So half are just the starting of labor. Okay. A quarter are where the membranes rupture preterm pre-labor. So we call that PPROM, preterm pre-labor rupture membranes. And then a quarter of all preterm births are iatrogenic or medically caused.
Right. A quarter?
A quarter. But some of those iatrogenic preterm births are medically necessary.
Right. So if you have somebody with preeclampsia, I mean, these are totally
really legit.
There could be some super legitimate reasons. Right.
So preeclampsia is the one that comes to my mind, HELLP syndrome.
Yeah, conditions that are dangerous to the
to
mother.
continuing the pregnancy.
What
But-
about diabetes?
I don't know as much about
Probably
that.
if there's some kind of intrauterine growth restriction,
Yeah,
that would be good
I feel like diabetes would be more likely to be
later
term.
on.
But I
Yeah.
think it is certainly a common reason for induction.
So what about, do they still have that thing where, I mean, I think I've told you that my sister was born at 5 pounds and they thought she was a month overdue. They had tried to induce a month before and it had been unsuccessful.
Thank goodness.
Yes. So how often does that happen? I wonder these days. You know, we have much more. I mean, that was more than 40 years ago. Sorry,
Your
my
sister? Oh no, you are in so much trouble because now we know which sister it is. So I don't think we really know how many of the iatrogenic preterm births are elective versus medically necessary. And I would say there's some gray area between elective versus medically necessary too. Like
Sure.
big baby.
Right.
You know, some of those things that they might say.
There's some arguable points
Like
there.
preeclampsia is without a doubt medically necessary.
Right.
Like there's no question there. But some of the others are probably a little bit more fuzzy.
Right.
So I don't know, but there is really a pretty big push to, because what happens is people actually request an induction at 39 weeks because they think that or even earlier, back in the day.
Right.
They think that they're done being pregnant and their
Right.
baby's full term and it's all good now.
Right.
And then actually there was a problem with the dates or...
Right.
I like to say some people are pressure cookers and some people are slow cookers. And if you're a slow cooker, it doesn't really matter if it's 39 weeks. If your baby's not developmentally ready, you're having an iatrogenic preterm birth.
Yeah, it can be too early.
Yeah. So I don't know the stats on it, but it's less than it was for sure. There's a lot less elective induction happening.
Yeah.
I mean, except that we did just have that Arrive trial come out a year or two ago, I think last year, that said that it was safest to induce at 39 weeks. So
Yeah,
I have a feeling that there's going to be the pendulum swings, and I have a
True.
feeling that it will swing back and we'll see more early inductions now.
Oh.
But there was a big move not to.
Stay
not to do
until
it without
39
reason.
plus.
Or later.
Yeah.
Or later.
Yeah.
A lot of hospitals here won't do it before 40 or 41 weeks. So.
Yeah.
So it's kind of, again, the times change and there's a cause and a response. And so it's tricky. But in any case, so how many preterm births have you had? Like, I know we didn't do our stats ahead of time, but.
Yeah, I did. I mean, really not very many. But I mean, I can think of one off the top of my head that, she was messaging me in the middle of the night at 34 weeks and
Early.
with a regular contraction pattern, and that labor went really fast and we did get her into the hospital in time, but it really cemented that feeling like, whoa, we've if it's happening, it's happening. So.
Right. I would have to say that was true. I think I've had 3 preterm births, and I would say that was true with all of them. One of them, her water broke. So one of them was
I have had one of those too.
Yeah. So in that case, actually her labor didn't start for days, and she elected to stay in the hospital and just wait for labor to start. But the other ones were fast. Really fast. And then when her labor did start, it was so fast that she had an unassisted birth in the hospital.
Oh, no.
She wasn't on the labor and delivery ward. She was on the antenatal ward.
Oh, no.
Nobody was listening to her. It was really, it was an interesting story.
Oh.
Her photographer made it, so one would have thought that somebody could have attended her birth in the hospital. But anyway, so yeah, I've had 3, all multips. None of them were first-time moms. None of them had the pregnancy interval less than 6 months. So that wasn't the case for them. And all of them were, at the end, they didn't have any sign of infection or anything like that. So they were all really unexplained.
So do you counsel your clients on prevention of preterm labor. Besides, I mean, because we're not prescribing progesterone, although some of our clients are doing co-care and they are taking progesterone based on their personal histories and risk factors under a doctor's care. But do you have anything that you say normally for prevention?
I think the most important, well, we always talk about healthy lifestyle factors at every prenatal visit, paying attention to your diet, exercising. But I do feel like if somebody has quite a few sources of stress or pretty severe sources of stress, we talk a little bit more about stress management than we would. But I mean, honestly, this is one of those things that sometimes there's not a lot you can do. If it's going to happen, it's going to happen. So the things they talk about are cessation of smoking and illegal drug use and drinking alcohol. And, so of course we do talk about those things, not necessarily in connection with preterm birth, but we do just
always talk
trying
about
to support a healthy lifestyle, to support
good nutrition,
person.
Reduction of stress, like we've talked about multiple times. Things that they also bring up on March of Dimes, I believe, when I was reading about it earlier, is removing yourself from an abusive relationship.
Which that's a whole
some
other...
of these things are really, easier said than done, but important. I mean, there's so many outside risk factors that could
and I would say having a care provider that you feel comfortable with, especially for people of color, somebody that's listening to you and that you're feeling safe with, that could help reduce some of the stress for individuals with, kind of demographic risk factors too. So access to care, access to prenatal care, really important. One other thing that we haven't really talked about that we don't offer, but in some communities there's the centering pregnancy model, group pregnancy model, that's been shown to reduce the risk of preterm birth and small gestational age.
I always want to know why. Like, what is it about this
Well,
thing?
they do quite a bit more education, so I think they're getting more of that healthy lifestyle counseling, and I think social support is probably a reducer of stress.
I was thinking more of you're around everybody working towards a similar goal, and so it's easier it's like when we're doing Weight Watchers together, it's easier for me to stick to my goal most of the time.
Neither one of us are quite on track lately, so it's an interesting example.
But having that
social
team is really helpful. So that's where I was going with that. But
I think that does help
social support,
accountability, and keeping on track of healthy habits.
Yeah, absolutely.
Yeah, for sure. Anything else we're forgetting to mention? I feel like I went through most of what I wanted to cover. It's really it's an issue. It's something that is just really important that we address. And I think mostly what we do is talking about calling us as soon as possible with those symptoms, because once in a while it can be headed off at the pass. You can get treated and go home. And
so we want to prevent.
Prevention is key,
labor.
For sure. All right. Well, I think that's it for today. Check us out if you're not following us on Apple Podcasts, Google Podcasts, and Spotify. We're on all of those. We're on another one, too. I can't even remember what it's called. Plus Instagram and Twitter and Facebook and www.modmidwives.com.
All right. Thanks, everybody.
Thanks. Have a great week.